RSV Academy. Shredding papers. The maternal vaccine against RSV.
Hello everybody, my name is Lewis Bond. I'm a pediatric infectious disease specialist and I'm the chairman of the RSVNet Foundation. And today I will share a very interesting publication of Beate Kampmann published a few months ago on RSV maternal vaccination. And it's a privilege to do that for the VRS academia. So RSV is a major cause of disease in children. There are 33 million patients, 3 million hospitalizations, and at least 120,000 deaths worldwide. Most of them occur in the first months of life. If we look at the different disease severities, we can see that 14% of all children are medically attended for RSV infection and 1.8% require hospitalization. And about 1 in 1,000 require intensive care unit admission to survive. And what is important is that there are high-risk populations such as prematurely born children and children with Down syndrome or congenital heart or lung disease, but the majority of children with severe RSV infection were previously healthy children. And if we boil down these important numbers, then what we showed in a recent major birth cohort study in 5 countries in Europe is that any RSV infection is observed in 26% of all healthy children. 14% of these children require medical attention, and again 1.8% require hospitalization, 1 in 56 of all children born healthy term. So if we want to understand the development of vaccines, we need to understand the concept of the RSV prefusion F protein. What you can see here at the left is the prefusion protein with at the top the site 0, which is highly immunogenic, inducing neutralizing antibodies. But at the same time, the prefusion F protein only exists for a fraction of a second. It's metastable, and it's actually the post-fusion protein that is stable but does not induce highly neutralizing antibodies. And that explains why by stabilizing the prefusion RSV F protein, you have a perfect vaccine candidate. So this vaccine candidate was constructed and tested in a series of studies. First, this bivalent pre-F subunit vaccine with a vaccine against RSV-A as well as RSV-B was tested in a human challenge study. So healthy adults were experimentally infected after vaccination with placebo or this specific bivalent RSV pre-F subunit vaccine. And what you can see is that there is almost sterilizing immunity induced by the vaccine. Even though there is major viral replication in the placebo group, there is hardly any RSV either by PCR or culture, and even the symptoms are almost absent in the vaccinees. So that led to the next study, which is a phase 2 trial in pregnant women, where women were vaccinated with placebo or vaccine, either with or without aluminum hydroxide adjuvant in a low dose 120 or high dose 240 micrograms. And neutralizing antibodies, and this is important, it's neutralizing antibodies, not just antibodies, but these neutralizing antibodies were strongly induced in the pregnant women. And as you would expect, these antibodies actually transferred nicely to the babies that were born. In the cord blood, you could see the exact same phenomenon that the vaccine induced highly neutralizing antibodies, regardless of dosage of adjuvant. So in this phase 2 trial, there was already a signature of efficacy. What you can see here in the vaccinees, with a 4 times larger population than the placebo group, there were less children with medically attended RSV infection or medically attended severe RSV infection, leading to an estimated vaccine efficacy of about 85 to 90%. So this was reason to take this further into a phase 3 trial. In this phase 3 trial that you can see here, the maternal participants were randomized, were vaccinated with placebo or vaccine, and there were a few lost to follow-up, not too many. And then these children that were born here were followed according to their intended intervention, and a 12-month and finally also for some a 24-month follow-up was done. So really extensively. And there was a nice little piece of information in this paper, as you can see, that in the vaccinees there were 5 children dying, whereas in the non-vaccinated group or in the placebo group, there were 12 children dying. So I think this is an interesting observation that there was a sign that maybe mortality was prevented. But obviously we don't know whether this was RSV related. But what we did know was that there was diversity among the participants. If we compare the vaccinees and the placebo and we look at participants, we can see a nice distribution of all sorts of ethnicities, and that there was a good representation, not just of white participants, but also of various backgrounds. If we look at antibody titers, we can see that the antibody titers were induced in the vaccinees, as you would expect, but really they were holding up until expected threshold of protection for 6 months. So what did we see in this trial in terms of real protection? Well, here you can see in medically attended severe RSV infection or medically attended any RSV infection, you can see that there is a strong vaccine efficacy of over 80% for severe RSV infection in the first 90 days, and still a strong protection of 70% in the first 180 days. If we look at less severe disease, the efficacy went down a little bit, but I think you will all agree that vaccine efficacy against severe disease is mostly wanted. And this was reason for the Food and Drug Administration to approve this vaccine. How about adverse events? If we look at adverse events between the vaccinees and the placebo, we can actually see that they're nicely, as you can see here, distributed among the vaccinees and the placebo group. If we look at adverse events of special interest, such as preterm birth or a SARS-CoV-2 infection, you can see that there is a very, very small, non-significant, largely overlapping confidence intervals of preterm birth and SARS-CoV-2 infection in the vaccinees that we do not consider a safety signal. And for all the other serious adverse events, again, we saw equal distribution among both groups. So in conclusion, and that is my little presentation that I wanted to share with you, is that we have a pre-F bivalent subunit vaccine, and we understand why it's working, because it is directed against this metastable pre-fusion F protein with this little tip of site 0 at the top that induces neutralizing antibodies. We have seen that protection is durable for at least 6 months. These children are protected with major benefit and a good safety profile. I thank you for your attention, and I hope you have a great day.